Hello, my dear students. This podcast will be about cementum structure. And as we know that cementum is a specialized mineralized calcified dental tissue that covers the anatomical root of human teeth. Cementum, as we see in this histological section, surround the whole root surfaces. Thus, it acts as a medium for the attachment of the periodontal ligament collagen fibers. The periodontal ligament fibers insert themselves inside this layer of cementum, and the fibers of periodontal ligament enter the cementum are called Sharpey's fiber. Thus, cementum serves as a medium for attachment of Sharpey's fibers of the PDL. The cementum by somehow resemble bone in many of its physical and chemical properties, like the amount of mineralization, like the type of collagen, but a little bit differs in very important facts that cementum is a vascular tissue, while bone, of course, is a highly vascular tissue. Cementum is insensitive. There is no nerve endings or nerve bundles in the cementum, but in bone we have multiple nerves and blood supply. As cementum deprived from bone, deprived from vasculature and innervation, it loses the ability to remodel. Thus, if cementum suffer from resorption, it's very difficult to remodel or to regain this amount of resorbed cementum. Thus, the ability of remodeling exists only in bone due to presence of high vasculature. We have a huge amount of blood supply, bring new cells, formative cells, resorptive cells, and permit for remodeling. Remodeling means we have resorption accompanied with formation, but cementum, as it's deprived from vasculature, it's avascular, there won't be the cementum won't show any remodeling. And as I said, any resorption in the cementum due to infection, due to pressure, due to extreme pressure, due to any fracture in the cementum, it's so difficult to be healed or repaired. The physical properties of cementum, as we see in this clinical picture, the cementum color is yellow in color, lighter in color compared with dentin, but darker compared with enamel. Regarding thickness of cementum, as we see here, the cementum very thin toward the cervical portion of the root and getting thicker toward the apex of the root. The cementum type toward the cervical area is called acellular cementum and could extend to a little bit to the middle or apical third of the root portion, while the cellular cementum mostly exists at the apical part of the root. The thickness, as we see here, is about 20 to 50 micron at the area of acellular cementum cervically, while cellular cementum increase in thickness to be about 150 to 200 micrometer. As we see here, this histological section showing the acellular cementum, very thin layer of acellular cementum as a cervical portion near the dentino-enamel junction. While here in the middle image we have the cellular cementum of greater thickness, greater than the acellular cementum exists cervically, and the last image shows very thick layer of cellular cementum. Cellular cementum means that multiple of formative cells entrapped inside the cementum, as the case exactly of bone, meaning that cementoplasts that formed this layer entrapped inside the formed matrix, forming cementocytes. Exactly typical to bone. The osteoblasts entrapped in the mineralized matrix called osteocyte. Also, osteoblasts that formed cementum when entrapped inside the matrix are called cementocytes. From these criteria, we have acellular cementum without any entrapped cells and cellular cementum with multiple entrapped formative cells. Regarding the permeability, of course, cementum is highly permeable compared with dentin and allow the nutrition and the transporting of some nutrition from the PDL toward the dentin. However, the permeability of cementum is higher toward the PDL compared with toward the dentin. The permeability toward the PDL is greater than toward the dentin. As we see here, this cementum surface toward the PDL, the permeability here is greater than the cementum toward the dentin. And of course, this will affect the existing entrapped cells in the cementum. Thus, the deeper cells toward the dentin will deprive from nutrition compared with the cells near the PDL. Cellular cementum, of course, is considered as more permeable than acellular cementum due to presence of cells, and these cells communicate together, thus allow the permeability to be more in cellular cementum if compared with acellular cement. Regarding the chemical properties, we have about 50 to 50 inorganic and organic. The inorganic as any hard dental tissues or even the bone, we have hydroxyapatite crystals, while in the organic, which about 50% formed of collagen, proteoglycans, and so on. Pay attention that this amount of minerals or inorganic substances of cementum makes the cementum or affects the hardness of cementum to be the lowest of the hard dental tissues. If we try to categorize the dental tissues according to hardness, of course, the hardest tissue will be enamel, followed by dentin, then followed by cementum. It's the least hard tissue. Cementum is characterized by containing a huge amount of fluoride, which I think a sort of protective pattern from the cementum, because it's very thin, highly permeable. Thus, it could be a functional adaptation to have huge amount of fluoride trying to protect itself from any bacterial invasion or any insult. Regarding cementogenesis, or the process of cementum formation, as any hard tissue, we have matrix formation and mineralization as well as maturation. Matrix formation, that responsible for secretion of protein, the collagen, the glycoproteins, the ground substances, and so on, while the mineralization and maturation is to secrete hydroxyapatite crystals parallel to the secreted collagen and intrafibrillar. Pay attention that the normal biological mineralization of any collagen fibers, that should be intrafibrillar. And we have to mention that cementogenesis and as dentinogenesis, as osteogenesis, the second part of formation is mineralization and maturation, while in enamel the formation of enamel or amelogenesis was consisted of matrix formation and maturation. Why maturation in enamel? Because the enamel is formed because the inorganic substances of enamel secreted once the matrix is formed, while in the other connective tissue structures or in the other ectomesenchymal structures as cementum, dentin, and bone, the mineralization await for a while to form matrix, then start to mineralize this matrix. Thus, the matrix formation, we have collagen type 1 and ground substances, while the mineralization and maturation, the secretion of hydroxyapatite crystals parallel and intrafibrillar to the collagen fibers. Regarding matrix formation, is exactly the same process of root formation as we see here. The epithelial root sheath of Hertwig, starting of epithelial root sheath of Hertwig, as you see here, epithelial root sheath of Hertwig starts to proliferate from the reduced enamel epithelium. This reduced enamel epithelium that are formed of the enamel organ compressed cells, and as you see here, differentiation of odontoblasts that start to secrete dentin, then the epithelial sheath of Hertwig will degenerate. This is the future cemento-enamel junction. That's the start of the root and the end of enamel, and this is the epithelial diaphragm. This histological section showing also odontoblastic differentiation, as you see here, odontoblastic differentiation and formed dentin, while as you see here, some cell rests exist here due to degeneration of the epithelial sheath of Hertwig that leaves remnants which are called epithelial rest of Malassez. And here you are the epithelial root sheath of Hertwig, dental follicle, DF stands for dental follicle, and as you see here at the apical part we have still epithelial diaphragm and the starting of odontoblastic differentiation. The remained tissue exists here is called dental papilla as long as we have no dentin, while at that part we have pulpal tissue. Epithelial sheath of Hertwig, and the tooth move occlusally toward the eruptive path of the tooth, leaving the root formation. Here it is. Let's remove all of these circles and lines to see the section properly. We have here the newly formed dentin. As we see here, the dentin, newly formed dentin, and here you are the odontoblasts, and these are the extra mesenchymal cells, undifferentiated mesenchymal cells that will be differentiated later on into cementoblasts, and the epithelial rest of cell rests that exist represent the remnants of epithelial sheath of Hertwig. These are the cementoblasts. The cementoblasts are protein forming cells, meaning that large open phased nucleus if we describe it by light microscope, but here in this section we have electron microscopic picture due to this obvious nucleus and these fibers. Of course, this is not a light microscopic picture, it's an electron microscopic picture, and the nucleus will be large with dispersed chromatin threads, meaning that we have multiple messenger RNA that secrete that's formed inside the nucleus, then will be transferred outside the nucleus to the rough endoplasmic reticulum. Thus, we have huge amount of ref endoplasmic reticulum, Golgi apparatus for the secretory granules product, mitochondria for the energy, and of course the secretory granules. As we see here, the collagen fiber and ground substances that are secreted from cementoplasts. Of course, the cells characterized by high activity of alkaline phosphatase to recruit more mineral content and enhance the mineralization later on. This is a histological section, decalcified section, showing the dentin. This is the dentin, and this is the covering cementum. And as you see here, part of the cementum is acellular, while other part is cellular, showing entrapped cementoplast in this matrix, thus called cementocytes. As you see here, let's remove these lines. Each cementum layer should lined by cementoid, which is a soft cementum matrix, and these deeply stained plump cells are cementoplasts. The cementum characterized by formation layer by layer, as any hard tissues, rhythmic pattern. Thus we have incremental lines. As you see here, we have incremental lines inside the cementum, as we will discuss later. This is the cementoid layer, and these are the cementoplasts. The cementum, as we mentioned, shows two main types, acellular and cellular. Acellular meaning we have no entrapped cells, while cellular cementum means that we have entrapped cementoplasts that are called cementocytes. The previous sections were ground section, while this section is decalcified section. As we see here again, the cementoid layer and the epithelial rests of Malassez or rest cells. And this is the cellular cementum with lacunae of cementocytes. As you see here, these are the cementocytes exist in spaces. As you see, cementocytes. This is a ground section showing the dentina tubules. As you see here, these are the dentina tubules of dentin, and of course this layer is Thom's granular layer, is the end of the dentin layer, represent looping of dentina tubules to protect the radicular dentin from this very thin, highly permeable tissue, which is cementum. And this is the acellular cementum, and as we mentioned, the thickness is about microns. As you see here, no cells, of course, and the ground substance shows the incremental lines that are called incremental lines of Salter, and these incremental lines are highly mineralized, which is unique feature for cementum. Every hard tissue, enamel, dentin, bone, the incremental lines represent rhythmic pattern of formation, and these lines are hypocalcified structures, except in cementum. These incremental lines represent hypermineralized lines or areas. As you see here, these indication for Charbet's fibers, and let's remember again what's meant by Charbet's fibers. Charbet's fibers are the periodontal ligament fibers that inserted inside the cementum. These are the periodontal ligament, and this is the cementum. These periodontal ligament fibers inserted into the cementum. The fibers that getting into the cementum from the PDL are called Sharpey's fibers, and these fibers, of course, considered as extrinsic fibers. What's meant by extrinsic? These fibers exist in the cementum, but it's not a product of cementoblast. It's a product of periodontal ligament fibroblast. Thus, they are called extrinsic fibers. Of course, the cementum is formed slowly at a slowly rate. Regarding the cellular cementum, thickness increase a lot gradually toward the apex of the root. The cellular cementum mostly exists at the apical third, at the bifurcation area of premolars and molars. The rate of formation here is faster than the acellular cementum, and this the result of entrapment of the formative cells. During acellular formation, the cells secrete the cementum and retreat away from the cementum, secrete cementum and move away from the cementum. Thus, the formation with slow rate, thus the cells can keep themselves away from the formed matrix. While in cellular cementum, the formation is rapid and fast, thus the cells could entrap inside the matrix, thus it's called cellular cementum. Is more permeable, as I mentioned before. This permeability comes from that the cellular cementum contains lacunae of cementocytes that are connected together, forming a system of communication. Of course, this system of communication, not as the case of bone, it's a little bit less, shows less communication compared with bone, but still we have communication between cells and each other. Thus, the permeability in the cellular cementum is greater than in case of acellular cementum. The cells, of course, contain cementocytes, imprisoned cementoblast. Cementoblast. Imprisoned means that entrapped inside the formed matrix. This is a cellular cementum. These are the lacunae of cementocytes, but you have to notice something very important. The lacunae of cementocytes shows one side deprived from processes, while another side shows multiple processes. Let's see this cell. As you see here, this side deprived from processes or minimal processes, while the other side shows more multiple processes. Why this feature exists in cementum? Because the cellular cementum, the cells in the cellular cementum directed toward the PDL more than the dentin. Why? Because the permeability from the PDL is greater. The movement of fluid from the PDL is much easier than if compared with from dentin, because these cells, these entrapped cells, need nutrition, need to get out or get rid of its products or metabolites, need oxygen, need to remove their carbon dioxide, and so on. These all vital processes need the cells to be toward something vital and filled with blood vessels and ground substances and so on. Of course, these criteria exist in the PDL rather than dentin. The dentin is highly mineralized tissue. We have dentinal tubules that connect the dentin towards the pulp, but it's a long distance to get their needs from the pulp through dentinal tubules, but their need could be easily achieved from the PDL, which is connective tissue. Okay, thus they direct their processes, most of their processes directed toward the PDL where they can achieve or gain their nutrition or get rid of their wastes. This histological section showing again multiple processes toward the PDL and few processes toward the dentin. These are cementocytes. In the decalcified section, we can say cementocytes, while in the ground sections, we mention them as lacunae of cementocytes, because in the ground section, the ground process remove any vital tissues. Of course, the cells are vital, thus the cells removed completely, but the remained is the lacunae of the cells. While in decalcified section, we can see the cells themselves. And of course, here the incremental lines are clearly obvious, these incremental lines of Salter, and this is the Thom's granular layer between the dentin and cementum. Incremental lines of Salter, the cellular cementum section again, and notice that the deeply positioned cells, wow, the deeply positioned cells are completely deprived of processes. They have no processes either toward the PDL or toward the dentin, because they are near to the dentin and the nutrition is very difficult to reach them. Thus they are completely dead cells toward the dentin, while those near the PDL, as you see here, wow, multiple processes and directed toward the PDL. This is the dentin side, of course, and this is the PDL side. Viable superficial cementocytes, while degenerated deep layers cementocytes, as you see here, no processes. We can find that some of the cemental layer shows alternating layers between acellular and cellular. As you see here, this layer is completely deprived of entrapped cells. Thus, this part is called acellular, while this part is cellular cementum, and this another part of entrapped cells, this is cellular, and another part is acellular. Thus, we can find alternating layers between acellular and cellular cementum. To compare between cementocytes and osteocytes, it's very crucial to understand the differences between cementocyte and osteocyte, because these differences reflect on the response of root or cementum to the pressure or any applied forces. Any applied forces on the bone causes bone resorption that's followed by bone formation or remodeling, while any pressure on the root resists any pressure for a long time, but if the pressure exceeds to its physiological limitations, there will be resorption, but without remodeling. As we mentioned before, that cementum is avascular, thus any resorption won't be repaired or regenerated easily. There is no remodeling process in the cementum. Thus, we have to know the differences between osteocyte and cementocytes to understand the response of bone or cementum to any applied forces. These are the cementocytes and osteocytes. As we mentioned, cementocytes shows only processes toward the PDL, while the osteocyte shows evenly distributed processes. Cementocytes and osteocytes by transmission electron microscope showing, this is a scanning electron microscopic picture to scan the cells from top view, showing both cells with multiple processes, but in the osteocyte the processes are evenly distributed, while in the cementocyte, as you see here, this part is very derived from processes. This infograph shows the differences and similarities between cementocytes and osteocytes. And this part is a homework, exactly as the homework that was announced in the Pulp podcast. We have a homework in the Pulp chapter, and this also the homework that will be discussed in the physical lecture, the differences between osteocytes and cementocytes. And I want you to read this infograph and know well the differences as well as similarities between osteocytes and cementocytes that will reflect on the response of both tissues on any applied forces during extraction, during orthodontic tooth movement. Any applied forces will be reflected on these tissues by knowing well their cells. This also comparison table between both cells, this also will be discussed in the physical lecture. The incremental lines of Salter, as I mentioned, they are hyper mineralized, which is a unique feature for Cementum. These are the incremental lines of Salter. They are also called cemental annulation. And by the way, these cemental annulation could be used to detect the age of a tooth. If we have a tooth for a cadaver, for example, and they need to know the age of this cadaver from the tooth, we can count the cemental annulation or the incremental lines of Salter and calculate the distance between each line, thus can calculate the age of this tooth exactly as the tree growing lines. And this is very crucial in the forensic odontology branch. They could use cemental annulation to determine the age of a cadaver or a remnants of a cadaver as a tooth. After describing both types of cementum, cellular and acellular, we now directed toward the dentin, and we need to check the junction between cementum and dentin, which is called cemento-dentinal junction. We have to notice something very important, that dentin is a product of dental papilla, which is ectomesenchymal tissue. Cementum is a product from dental sac, which also is a ectomesenchymal tissue. Both are mesenchymal tissues. Thus, the junction here between, as if between two connective tissues. Thus, we will find that there is an intermingling between the fibers of the cementum with the fibers of the dentin, and both are collagen fibers. This case is not the case as in dentino-enamel junction, because in dentino-enamel junction the dentin is formed of collagen fibers while enamel is formed of enamel proteins. Thus here the junction, of course chemically, but we have different proteins or different products. But in dentin and cementum, both contains collagen fibers, and the intermingling between the fibers forms this dentino or cemento-dentinal junction. In permanent teeth, the cemento-dentinal junction is straight, while in deciduous teeth is scalloped. So far, we couldn't find any significance of this variation between permanent or deciduous, but could anyone explore the significance of these changes? Regarding cemento-enamel junction, as you notice that cementum has junction with the dentin or the underlying tissue of the cementum, which is dentin, and also has junction to the enamel at the cemento enamel junction or cervical line. And we discussed this before during root formation and during enamel or amelogenesis, that we have clear cut between enamel and cementum. This as in case of A. As you see here in this case, case A, we have clear cut between the crown and the root and edge to edge contact between cementum and enamel. While in case B, as you see here, we have bared dentin, part of dentin deprived from coverage or cemental coverage, and this is due to, hope to remember, due to persistent epithelial root sheaths of Herdwick that persist at this area, thus deprive this dentin to be covered by cementum. At case C, we have here the cementum cover part of the enamel, and this cementum is called afibrillar cementum, and the afibrillar cementum is formed due to, hope to remember also, due to degeneration of the reduced enamel epithelium that covers the enamel at this area, thus permit the dental sac to differentiate into cementoplast and form this unique type of cementum, which is called afibrillar cementum. The percent of occurrence of edge to edge cemento enamel junction is 30% of the cases, or 30% of the junction is edge to edge. While bare dentin, and it's thank God that bare dentin is a very minimal percent, which is about 10%, because at this case we have bare dentin, meaning that the dentin is exposed to the PDL, meaning that it's exposed to the movement of fluids. It can be exposed easily, and any stimuli transmitted into the pulp, leading to pulp death, while there is no any caries or any obvious cause or reason for this pulp death. Finally, the afibrillar cementum form about 60% of the cemento enamel junction. Pay attention to something very important, that if we have the tooth, not all the cervical line shows one of these junctions. What's meant by that? If I have this a tooth and this is a facial surface, the cervical line here could be from the overlap of afibrillar cementum. Proximally, could we have a part of the dentin deprived from cementum? Lingually, we can find edge to edge in cemento enamel junction. Thus, the tooth could show all of these junctions in one tooth. We have no category. This tooth shows this junction, while this tooth shows another junction. No, we can see all of these junctions in one tooth. Part labially with a fibrillar cementum, lingually with edged edge, proximally another fibrillar cementum, mesial or distal, bare dentin, and so on. These another views for the different cemento enamel junction with edge to edge, or bare dentin, or here, by the way, case A here represent afibrillar cementum, while case C here shows edge to edge cemento enamel junction. From previously discussed parts, we can of course notice that cementum has three types: acellular cementum, mostly at the cervical portion, or cellular, mostly at the apical portion. We can find area of alternating, but this is in most cases. And the third, of course, type, which is afibrillar cementum, that exists cover part of the enamel as a cervical area. Function of cementum, for sure, it occludes the sensitive dentinal tubules. It, it is the crucial role of cementum is to occlude the dentinal tubules. Not only that, the second very crucial and important role is to perform attachment to the PDL by Shore-base fiber. As you remember, hope to remember that Shore-base fibers are the extension of the periodontal ligament fibers into the cementum. Of course, it keeps the attachment apparatus intact. The cementum keeps the attachment of the tooth to the adjacent bone. Also, cementum have continuous layer of cementoplast. Cementum shows continuous deposition or formation, because we will discuss this later during eruption and shedding of the tooth. We have eruption during eruption, and the tooth reach its occlusal plane. This the upper tooth and this is the lower tooth. During masticatory forces, will be attrition, and attrition will create gap between the teeth, which is very difficult to be exist, because there will be masticatory forces. Thus, this gap should be closed by continuous eruption of the tooth. Thus, this continuous eruption of the tooth to compensate the attrition should be replaced apically by continuous formation of cementum. Also, if we have any condition, minute fracture or resorption of the root, the cementum can heal these parts, but as I mentioned, it's very difficult to attain reparative cementum. But it could happen, but not as in case of any defected bone. Any defected bone can be easily regenerative and repaired due to presence of high vasculature in the bone, but any defect in cementum is rarely to be repaired by cementoplasts, and could happen, but with less rate than in the case of bone. As you see here, area of resorption and repaired cementum occurs at this area. This root resorption, as you see here, this part of the root resorbed, and a cementum-like tissue could exist to heal this area. Also at this area we have reparative cementum that can occur in a resorbed area of the root. Age changes of the cementum. The thickness, of course, increased by age. Why? Because we have cementoplasts that exist all of the time and form cementum all of the time. Exactly as the case of dentin, we have all of the time odontoblasts. Thus, the size of dentin increase on the expense of the size of the pulp. The pulp decrease due to formation of secondary regular dentin. Here also in the cementum we have all of the time continuous layer of cementoplasts that increase the thickness of cementum by life. But in some cases the increase will be abnormal thickening, increase so much or too much, and this hypercementosis, increase in thickness which is considered abnormal, could be localized in one tooth, as we see here in this histological section, decalcified section, or generalized in multiple of teeth. We could determine increase in cementum thickness. As you see here, these areas are hypercementosis. The hypercementosis could be divided into two parts: hypercementosis hypertrophy or hypercementosis hyperplasia. In case of this increase in cementum thickness with multiple Sharpey's fibers, multiple periodontal ligament fibers enter in this cementum, meaning that this tooth is highly attached to the adjacent bone. Thus, this cementum is called hypercementosis hypertrophy, meaning we have functional tooth, increase in number of Sharpey's fiber, indicative for multiple or indicative for functioning teeth. While if this cementum increase too much and the Sharpey's fibers are minimal, meaning that we have a surface area of cementum without attachment to the adjacent periodontal ligament, then to the adjacent bone, this is a non-functioning tooth. And by the way, this non-functioning tooth could be lost with time. And this occurred in cases such as if we have a patient come to your clinic and suffer from, for an example, a very deep, painful caries in one of his right teeth. Thus, this patient neglect this painful tooth and leave this painful tooth without treatment and directed to eat on the other side, leaving this side non-functioning without any masticatory forces because of pain. Thus, in these teeth, the reaction will be cementum will be formed too much because cementoblast exists and there is no masticatory forces. Thus, the formed cementum doesn't show Sharpey's fiber. This is a non-functioning tooth, and you can detect or diagnose this non-functioning tooth from an X-ray because we have a huge amount of cementum in one side, generalized. You will mention that to the patient. Are you neglecting this side during your eating? Of course, the answer will be yes. I am never, or recently, I never use this side because the painful tooth, and I direct my whole masticatory forces toward the other side. And if you have a look to the other side, you will have maybe hypercementosis with multiple of Sharpey's fiber. Of course, Sharpey's fibers won't appear in the X-ray, but histologically, if we take a section, these hypercementosis or this increase in cemental layer will choose multiple of Sharpey's fibers. Here you are, hypercementosis hypertrophy and hypercementosis hyperplasia. By X-ray, this is a histological section showing hypercementosis localized, and by X-ray, this is a localized hypercementosis. Of course, by X-ray, I couldn't determine whether if it's hypercementosis hypertrophy or hyperplasia. We have also cementicles, as the case in pulp aging. We discussed this during pulp, that we have denticles or pulp stones which were true or false. Here in cementicles, we have only cementicles without any categorization being true or false, and these calcified tissues exist in the PDL near to the tooth structure, and these cementicles arise from the epithelial rest of Malassez that where exists in the PDL could shows calcification. Thus, these cementicles could be free in the PDL or attached to the root surface or embedded in the cementum. These are cementicles and their causes, and these histological sections show different cementicles based on their location. The permeability of cementum, of course, the permeability will, from the PDL, which was the main source of nutrition, will decrease by time, and thus the superficial cells will be vital. More and more superficial cells will kept vital, while the deeper cells of cementocytes getting deprived from nutrition, thus getting degenerated and will be non-vital cells. Thank you, and hope the content of this lecture be beneficial for you. Inshallah, see you next podcast. Thank you and bye.